the features of cerebellar dysfunction. And what is the first feature we are going to discuss? Titubation. Okay, we are going to discuss about titubation. What is titubation? Titubation is essentially the nodding of the head. And this nodding of the head can happen either in the antero-posterior direction or it can happen in the side-to-side manner as well. The antero-posterior titubation, just like this, is called yes titubation. Okay, it is called yes titubation, whereas the side-to-side, this is called no titubation. Okay, now, which is more common, yes or no? The more common one is the yes titubation. So essentially what happens in titubation is the inability to hold the head and neck steady and upright. Okay, and remember, this movement or this sort of tremulous movement, that is titubation, disappears when the patient is lying down as well as when the head is fully supported. One more additional clinical point, other than cerebellar dysfunction, what are the other clinical conditions where you get titubation? One is essential tremors and the second condition is cervical dystonia. Clear? Okay. The next feature of cerebellar dysfunction is truncal ataxia. Okay, truncal ataxia. So we'll see what is truncal ataxia, and very importantly, you should know how to demonstrate truncal ataxia. Very important. Are you seeing this picture here? Okay, now just like this, what you have got to do is ask the patient to sit with the buttocks resting on the edge of a firm surface, and you see if the patient can keep his balance in this particular position without the help of extremities. Okay, so just coming back to this picture here, can you see here? So this patient has good truncal stability, but in a patient with cerebellar dysfunction, what can happen? The trunk can sway. There can be a swaying of the trunk. He might require the extremities, to hold balance while he is staying there in that couch. Okay, right. Now, the third one, the third clinical feature of cerebellar dysfunction is a gait ataxia. Now, how do you assess this? See, the gait of the patient in a suspected cerebellar dysfunction should be assessed. Okay, now for the assessment, you have to first observe the patient, number one, while standing. While standing, you please assess the volitional posture of the patient and you see whether the patient is swaying or not. He may sway in that particular position. Number two, while walking, you assess the volitional matlab what? The voluntary foot placement as well. And what will you observe for? You will look for any sort of ataxia of gait. Now, please understand that patients with cerebellar dysfunction will have gait ataxia and they usually try to compensate for this unsteadiness by virtue of a broad stance. They'll keep the legs a bit apart. So usually the patient has a broad stance and a broad-based gait. Now, how broad is broad? See, the distance between the two medial malleoli should be about 12 centimeter to call it a broad-based stance or broad-based gait, whatever it is. Okay, right. So that is also clear. Okay, now just see this. This is just a snap taken of a patient. Now look at his stance here. Can you see that there is a significant distance between the two medial malleoli? Now, this is an attempt by the patient to avoid any sort of swaying. Now, this is a compensatory mechanism by the patient so as to avoid any sort of swaying. Got it? Okay, right. Now, when the patient is walking, the sort of a gait in a cerebellar dysfunction is often called a reeling gait, drunken gait, or even ataxic gait. Okay, these are the names given. Okay, reeling, drunken, ataxia gait. Okay, now what are the gait characteristics of such an ataxia gait? Now this might be important because when you try to describe the gait of a patient, you have to go through these points. So when the patient is standing up from sitting, usually he will sway, there will be a wide stance, and the patient will be unstable. While he is standing, he'll have an erect posture, the stance base will be wide and he'll have a tendency to sway. While he is walking, the initiation is fine, the speed is normal or slow, wide stance, staggering steps, variable, cadence, the number of steps per minute. So variable cadence will be there and also variable step length will be there. Okay. Then turning, see, there will be a tendency to fall. But unlike extrapyramidal disorders, there will be no freezing. Okay. And other maneuvers, tandem walking will be impaired in patients with ataxic gait. Got it? Right. Now, I told you, patients will have broad base as a compensatory mechanism. Now, when you try to examine the patient, now suppose if you see a patient in whom you are suspecting a sort of a cerebellar dysfunction, but apparently he is having, is having a stance there and he's trying to walk without much difficulty, but, but you get a feeling that he's trying to compensate by a broad base. How will you overcome this compensation? Important question. Okay, and the picture tells you the story. So this is by tandem walking. So what is done is, ask the patient to step along a straight line, placing the heel of one foot directly in front of the toe of another. An inability to walk in a straight line is the most sensitive clinical test for gait ataxia. And generally we say that if a patient makes more than 2-step correction out of the 8 steps while he is doing a tandem gait, that is said to have, an impaired tandem gait. Okay, that is called tandem walking. Okay, so that is another clinical point that you should know. Okay, so basically when you are trying to do tandem walking, you're trying to, avoid that compensatory mechanism. And there is no need to do a tandem walking in a patient who is having a very significant gait ataxia. Then what is the point? See, very significant gait ataxia where he is significantly swaying even with a broad base, but means, it's significant cerebellar dysfunction. There is no point doing a tandem walking there. Tandem walking is done when you are suspecting cerebellar dysfunction, and what you're trying to do is you're trying to avoid the compensation and bring out that gait unsteadiness. Got it?